Hello and welcome to Tuesday Talk, Project Open's weekly series to bring the topics of education, recovery, among others, to the forefront of local conversations. Project Open operates in three primary domains: prevention, treatment, and recovery. And today I'm very excited to welcome our expert guest who is going to be talking about a subject related to the treatment and recovery side of things. We're excited to welcome Mr. Donald McDonald. Donald is a thriving person in recovery from severe mental and substance use disorders since 2004. Donald's background includes being a consumer of services, provider of clinical services in multiple settings, health policy advocate, and recovery community leader. Previously, Donald served as a national field director of Faces and Voices of Recovery, the executive director of Addiction Professionals of North Carolina, and the director of advocacy and education at Recovery Communities of North Carolina. He spent the last several years at JBS International providing training and technical assistance to rural and underserved communities across the country as they built out their behavioral health services in response to the overdose crisis and the pandemic. And that's how Gerald got connected with Project Open. He was our technical assistance lead, and we are very grateful for everything he's done for us so far. Donald's current role is Chief Recovery Officer with All Sober, a startup public benefit corporation which is creating a comprehensive recovery ecosystem on the web due to launch this fall. He is a war veteran and former preschool music teacher, husband, father, grandfather, and social worker. He is a licensed clinical addiction specialist and a recovery coach professional and holds a Bachelor of Education from North Carolina State University and a Master of Social Work from UNC Chapel Hill. Donald is a proud recipient of the NCADD Bronze Key Award and the North Carolina Dogwood Award. For self-care, he loves hiking with his dog, eating dinner in front of the TV with his wife, Jill, and visiting recovery community centers and pie shops across the country.
Coming
Donald,
your way.
again, I can't wait to hear what you have to say. I know our listeners are excited to hear what you have to say. Thanks so much for joining us, and take it away.
Thank you very much, Akil. I appreciate that. And I'm looking forward to coming to see your recovery community center and visiting your local pie shop very, very soon. And thank you for sharing that. All right, folks. At last, identifying and embracing recovery pathway bias. What in the world does this mean, and why is it so important? And I've got to tell you that right now, with 93,000 lost souls to unintentional drug overdose, it has never become more important for folks in the helping space to address their internal biases, their implicit biases, anything that gets in the way of our providing optimal care to vulnerable human beings in our charge. And I'm going to point out a few things that may be present in your practice, in your organization, in your community, but I'm also going to provide some potential solutions and connectivity with some national organizations that may be helpful. You see here, we've got a lovely pathway through the woods there with just a little bit of a ghost of a coyote there. And so to explain the coyote, that is something that we picked up from Don and Kateri Koyas with the White Bison Incorporated in Colorado. This is an indigenous American recovery pathway and a underlying ideological construct that has helped to guide the recovery movement in the United States into a direction that is very much community-centered. When we invited him to North Carolina to share with addiction professionals of North Carolina's conference, when I was the director with them, he shared stories about coyotes and how we, all of us advocates and activists, are a bunch of yapping coyotes. And the fascinating thing about coyotes is when you bring these little feral dogs, clever tricksters, into a band, to bring them into community with common purpose, they can achieve some rather startling ends, including taking down a grizzly bear, if that's what they want to do. So we're Coyote Clan activists. We advocate on behalf of the marginalized populations we serve. We address bias and prejudice. We dismantle discriminatory barriers to freedom and wellness for all human beings. And that's what we get to do on the daily. Isn't that super exciting? My new organization, I'm so excited. I've been with them now for just over 3 months, all sober. This was born out of a family member's experience of discovering what a siloed and fractured and difficult landscape behavioral health prevention, harm reduction, treatment, and recovery support services can be. So they thought, why don't we bring together everything into one place? Makes sense. And that's what we're going to do. We're going to launch this fall. And it's a movement created to provide the millions of Americans living with substance use disorder and their families and loved ones with all the connections, information, and resources they need as they journey through recovery. We're going to help end the stigma and shame of addiction, inspire people in recovery to thrive. We're going to celebrate the recovery lifestyle. And we have a foundation at our disposal that is going to benefit the public good by helping to fund treatment for those who cannot afford it. And I'm super excited to be a part of all of that. So keep an eye on us, allsober.com. Follow us on all the social media channels, and exciting things coming down the pike. Let's talk about what a peer is. You may have an idea of what this is, but I'm going to use this in its most general way, that this is one of equal standing with another, an equal, especially when belonging to the same societal group. So in our space, this is any person with lived experience in recovery from mental and substance use disorders. It can be any clinical professional in your practice or ancillary folks or support staff with lived experience as a part of their toolkit that they bring to the table. And lived experience is a powerful tool. Any non-clinical professional, and this speaks to the workforce that is surging in the United States of America, as we have recognized the value of people with lived experience who have received additional training and supervision and are integrated into all levels of care and can work independently as well to help guide people through multiple pathways of recovery. They are resource savvy, they're harm reduction informed, and trauma informed folk. And this is an amazing workforce that we get to work with, and the administration recognizes this as well. And we're seeing
Hey guys, looks like we might have lost Donald. Hang tight for a second and give him a moment to join. And I've got PowerPoint over here, and some of the stat that we was in a conference recently, and they had said that oftentimes peer support is more effective in treatment than counseling and treatment itself. And so I think Donald was kind of emphasizing on the peer support side of someone's journey to recovery. And welcome back, sir.
I'm terribly sorry about that. I'm not sure what happened.
It's all right. Take it away.
Okay, take it away. So peers. All right. So we've established that ground level that we're talking about people with lived experience in all aspects of our workforce, including peer support specialist, a title that they have been bestowed. So let's talk about biases. What are biases? Well, these are neither positive nor negative in general, but they can have positive and negative outcomes. This is simply an inclination of temperament or outlook, especially a personal and sometimes unreasoned judgment or a prejudice. Bias, prejudice, stigma. These words can be used interchangeably as they relate to people who use drugs, people experiencing substance use disorder, people in recovery. One of the insidious things about bias is that it can be implicit or subconscious. And this refers to the attitudes or stereotypes that affect our understanding and our actions and our decisions in an unconscious way. And they encompass both favorable, like, I just don't know why I love these people, or unfavorable assessments of individuals or groups of people. And they get activated involuntarily and without our individual awareness or intentional control. That means that we get hijacked. We get hijacked by our attitudes, by our stereotypes, by our biases, both favorable and unfavorable, about groups of individuals. Who would leave that unexplored if you are working with vulnerable folk? Who would leave that unexplored? This is a thing. This is a fact. Implicit bias exists. Data support its existence. And that's what we have to do. We have to look at these data, not our perception. I'm not biased. I'm not prejudiced. I don't discriminate against anyone. Super. I'm glad you feel that way. But look at these data. We have data that show around 80% of people have access to chronic illness recovery management as it relates to asthma, hypertension, and diabetes. Yet 10% of us who experience this chronic illness of substance use disorder, for which we have 5 decades of splendid research indicating that it is indeed a multifactorial biopsychosocial chronic brain disorder with evidence-based treatments. Why do only 10% of us have access? I would contend to you that this is an example of bias at work. This is a discriminatory barrier. Let's talk about stigma. What is stigma? Well, I prefer this explanation the most. This comes from the 2015 International Conference on Stigma from Howard University. Degrading and debasing attitude of a society that, listen for it, discredits a person or group because of an attribute. That means the entire content of one's character, the depth and breadth of this three-dimensional soul, this husband, father, daughter, mother, gets discredited, gets negated because of an attribute, whether it's the color of your skin, your race, your religion, your national origin, your sexual orientation, your gender identity, your ability status, your diagnosis. Discredit. And when we do that, when we label folks with a one-dimensional label, it allows us to violate their human rights. It diminishes their opportunities to be fully human, to fully engage in the citizenry. It hampers the pursuit of happiness and contentment. And this is as it relates to the founding of this country, that life, liberty, and the pursuit of happiness is why this country was founded. So stigma, at its core, left unchecked, evolving into discriminatory practices and behaviors, is just downright un-American. Who wants to be a part of that? I don't. Hey, Demi Lovato, what's up? So Demi Lovato, how you doing? This is, remind me tomorrow. My computer's trying to take over. All right, Demi Lovato in the news. And this is what kind of inspired me to really dig into this exploring biases. Are you sober? What kind of sober? Demi Lovato's recent admission that while she is abstinent from the drugs with which she experienced the greatest problems, she reports that she sustains a manageable relationship with other drugs like alcohol and cannabis, sometimes referred to as Cali sober or California sober. I did not know that until I read it in the news. And some of the reactions within the addiction recovery community were very emotional and at times vitriolic. And I wondered why so many people have a problem with a person's drug relationship successfully transitioning from chaos to moderation. We may not believe them, but why are we feeling some kind of way and acting out on it? And I found that the judgmental and intolerant reaction is disturbing, but I'm made most unwell when it is among my professional colleagues. If we have a patient or a participant with severe opioid use disorder, And they come to us with a chaotic relationship with opioids and stimulants, and they achieve abstinence from those substances, but clinically are maintaining what is manifestly moderation with maybe alcohol and cannabis. Have we not achieved something in partnership with that individual that is measurably, clinically amazing? She was more well than when she entered into our office. And some argue that what she has done is dangerous. I saw comments like that. This is dangerous. Her admission and our acceptance is somehow advocating for drug use, a harmful influence on youth and people in early recovery. But I don't see anybody advocating for anything harmful. Among Demi's supporters during this time, what I saw unfolding on social media is people advocating for personal autonomy. I also see the injury that is caused by, now wait for it, and I'm not discriminating against any culture, but a yoke. And picture a yoke, two oxen with a wooden yoke. And there's ancient literary figurative speech where we talk about things being violently yoked together. And what we have is 12-step culture and addiction medicine in an unintended fetter that is potentially harming both communities. Now, first, to set the level, and we're going to talk a little bit more about this in a minute, what is recovery? If the individual says so, moderation is their recovery. Harm reduction is recovery. Pharmacotherapy is recovery. Abstaining from chaotic drug relationships is recovery. I encourage my professional comrades among you to revisit your respective licensing and certifying boards' code of ethics and check yourself. I better understand the emotional reactions from certain peer recovery mutual aid society members, lay folk in recovery, members of Alcoholics Anonymous and Narcotics Anonymous. I get it. I reacted the same way when I was a member of that culture and had not become a clinical professional. But I even urge people in the rooms to revisit this issue in your foundational literature and ask yourself if your reactions are principled. Social media was alive with hate and vitriol and disgust and fear. And so I'm a member of both cohorts. I'm a member of a 12-step community, and I'm also an addiction professional and mutual aid cultural member. And I must concede that I didn't wake up woke. My recovery pathway bias in the early years of my practice infiltrated my professional ethics for years and resulted in harms in the name of help. And in the vein of clinical humility, I tell you now, I was complicit in harm against participants when the hat I wore as a mutual aid society member trumped the hat I wore as a clinical professional. And for decades, the healthcare provider milieu has been dominated by people with lived experience. We bring great gifts and strength to this space. People in recovery from substance use disorder are drawn to this space. We want to help people find the freedom and wellness that we enjoy. Lived experience is not a requirement for clinical professionals, but it is for this surging peer-based workforce and recovery coaches. And we have to be mindful of that. This duality will be present. These biases are worthy of being explored. Peers play an integral role in our behavioral health continuum of care. For all addiction professionals in recovery, though, it is normal to harbor preference, passion, exceeding passion for our recovery pathway affiliation. We all have biases. They are not inherently bad. If we keep describing biases or prejudice as bad, no one's going to want to talk about it and get canceled over it. We have to explore these. However, when our biases impact the quality of care that we provide and cause harm, this is a bad thing. This is discrimination. This field ought to strongly urge all of its professionals to hold space for its people to explore these biases, to embrace them for the positive strength that they may hold, and to be mindful of the barriers that they can provide. So when this happened, I dug into ethics. I dug into clinical provider ethics. I dove into peer ethics, and I dove into medical ethics, because that's at the root of it all. These are ancient. The 4 pillars of medical ethics are non-malfeasance, beneficence, justice, and autonomy. And when we contemplate any therapeutic course of action, we are supposed to ask ourselves if this approach will cause no harm. First, non-malfeasance. And then we consider the appropriate therapeutic value or health benefit of this action for this specific individual or participant, and that's beneficence. Non-malfeasance and beneficence are the binary lodestar of all helping professions. Do no harm, do good for this individual. But outside of clinical social work, and I'm a social worker and I do have a bias for that pathway, outside of clinical social work, the other 2 pillars seem to be less discussed. Justice. It's this concept of ensuring that all people have equitable access to quality care. This is probably the most ignored of our 4 pillars. How are we going to go about promoting equitable access to care when we are complicit in a structure that is designed not to be equitable? And autonomy is our ethical imperative to proceed in partnership with our patients, our participants, our clients. This is difficult as well if we are holding biases on board. We are called upon to value their voice and their choice and their desires as strongly as our own. And what this creates is intraethical conflict. You can have conflict within your professional code, and you can have conflict between your personal code. What if we suspect that a particular instance of respecting a person's autonomy may lead to harm? Can we coerce a therapeutic pathway or end our provider relationship when we disagree with what they're doing? Can we? Ask yourself that. In the end, do such extreme measures balance towards beneficence? Then add interethical conflict with one's personal code, as influenced by our cultural affiliation and our socialization, and we've got quite a complicated case study. Or are we, in the instance of behavioral health, in the instance of addiction, overcomplicating this ethical struggle? Is it not less acute? And if I'm speaking to a number of hospital employees and primary care practice folk, you know what I'm talking about. Are we less paternalistic in our approaches to caring for people living with diabetes or hypertension? It's my contention that this disparity in our approaches to addiction versus other chronic illnesses, even chronic illnesses with flagrantly behavioral issues like my hypertension. My hypertension has behavioral issues that when I do not conform or with my recovery management protocols can create quite a burden on my family and on the healthcare industry and on taxpayers as well. But we don't get feeling some kind of way and cut people off when we've got them prescribed lisinopril for their hypertension, and they're still eating fried chicken and sitting on the couch watching Netflix. Or even if they're missing doses of their lisinopril, or which is a medication for hypertension commonly prescribed, or they don't show up for office visits. Sometimes y'all still prescribe. I know it happens for me. Maybe that's a privilege that I enjoy. So why do we have this issue with this contrast between medical surgical ethics and behavioral health ethics? And I think it's because morals are still part of the behavioral health body yet to be excised. They're not inherently bad. Morals are great, but allow them to trump your professional ethics at your peril. Most ethics philosophy professors likely had their syllabi with ethics are complicated. But I don't see honoring autonomy with equal measure to that of the other pillars of medical ethics as overly complex. We do it daily with other chronic illnesses, even with those with behavioral components just as deleterious as substance use, like hypertension and diabetes. Respecting autonomy is long overdue in behavioral health treatment, and it won't be easy for many of us who grow up haunted by the ghost of the moral theoretical model of substance use disorder. Some clinicians and peers argue that we have a duty to tell people the truth so they can truly recover. This comment came right from LinkedIn from a psychiatrist and a professor. We have to tell people the truth so they can truly recover. And this played his hand, that he had this concept of what true recovery or real recovery is. Very dangerous stuff. In the context of treating addiction, this business of telling people the truth and truly recovering are moving targets. What is the truth? What is recovery? And we're going to dig into that. Some people's truths in our space, including our beloved founder of Alcoholics Anonymous, Bill Wilson, was a white light experience. And the father of peer recovery support services, we discovered this indigenous American activist named Handsome Lake, divine light experience. That's their truth. That they've had a burning bush and a divinely guided pathway. That's their truth, and it's beautiful truth. But as that's the moving target that I'm talking about. And for some, the pharmacotherapeutic treatment of their opioid use disorder and a healthy friend group and meaningful work, that's their truth. For others, simply accessing social factors of wellness, social determinants of health, addressing trauma and mental disorders, and finally ending a chaotic relationship with drugs, that's their truth. That's their true recovery. And these are the many and beautiful pathways of recovery. So we don't know Demi's truth, but we have an ethical responsibility not to rally the defenses around our subjective truth. Next slide. Yes, indeed. That's me. I'm on it. All right. Let's visit ethics. If you are a peer support specialist, you're not necessarily a nationally certified one with NADAC, but that exists. And this is the one I grabbed. Your own state of Illinois and other folks who are watching this presentation throughout the country, your states likely have a certification and likely have an ethical code that warrants your visiting it. And this may create intraethical conflict between your personal code from your culture and your professional code that you've signed up to practice. And this from peer recovery support specialists have a responsibility to help persons in recovery achieve their personal recovery goals and promote self-determination and personal responsibility and empowering the inherent self-directed recovery. Self-directed recovery is a foundation of SAMHSA's definition of what recovery is. It's self-directed. We have an opportunity. We have a responsibility to advocate for the people we serve, and we have a responsibility to preserve an objective and ethical relationship at all times. Okay, that's the opposite of passion. That's the opposite of ecstasy. Okay, this is addiction professional practice, and it's complicated. Okay, recovery is amazing, and I'm passionate about it, and I have experienced ecstasy in my recovery. But when I decide to insert myself into these systems of care, and to become certified and educated and recertified, I have a responsibility. So take a look at that. I'm not saying our biases are bad. I'm saying we got to take a close look at what our ethical considerations are professionally and personally. Let's take a look at NADAC again, the National Association for Addiction Professionals, as it relates to clinicians, certified and licensed addiction professionals. And as you can see, there are many here, but I've highlighted those that align with medical ethics. And the very first one that they throw up there is autonomy. Allow each person the freedom to choose their own destiny. Not an easy thing to do when we believe we know better. Yeah, I know. I've been there. I've been there. I've been there as a provider of care, and I've been there as a family member. And it's not easy. Beneficence, justice, and non-malfeasance are present. Okay, that's ethical codes if you've decided to roll your recovery pathway into a professional, paid, certified, and licensed workforce integration and things to consider. All right, let's take another peek at recovery pathways. And this is super exciting because sometimes when we have a recovery pathway that we've been a part of, we can have a singular view. We become pathway centric, but it may bake your noodle to know that there are lots of pathways to self-defined recovery from chaotic alcohol and drug use. Let's take a look at some from our friends at Unity Recovery Community Organization in Philadelphia. Robert Ashford and friends helped to organize this together. And we need to understand there are many pathways of recovery as a first step to uniting these communities into an ecumenical culture that will help to end discrimination and dismantle these barriers for people. 12-step is often present in our communities. I'm deeply gratified for that. When I ended my treatment event nearly 17 years ago, I had over 500 diverse 12-step type meetings to choose from. Deeply gratified. However, we've been experiencing gradual growth and choice in mutual aid supports, both in person and digital. The pandemic has helped to blow this up as well. Super exciting. We've got folks who prefer a secular pathway. Okay, they don't want religion or spirituality or any talk of the unseen to be a part of their pathway. And we've got stuff like SMART, SOS, and LifeRing. And we've got non-secular, I would actually describe 12-step as non-secular, but in this instance, non-secular meaning basically religious or rooted in religion. And that ought to be your right. I can remember folks early on in 12-step who were deeply Christian and were basically asked within this culture to kind of rein that in a little bit in their practice, in their pathway. So we have folks like Celebrate Recovery and Recovery Dharma and Refuge Recovery to help with that. And I'm really excited about harm reduction mutual aid. We've got something out there called Harm Reduction Works. God bless Jess Tilley and friends like Megan Hetfield, my friend, who helps to blow this up nationally and digitally. If the opposite of addiction is connection, then we need not wait for connection when folks have decided to stop using drugs. People who use drugs need community as well. And it will lead to a less chaotic relationship with drugs. Oops, sorry about that. Next, let's talk about definitions of recovery. This is my document. I created this. There are some official and unofficial definitions of recovery. These official definitions down at the bottom, Connecticut Community for Addiction Recovery, they embraced what is actually kind of the third tradition in 12-step communities, which is the requirement for membership, which is simply, a desire to stop drinking, come get you some, or stop using, come get you some. They extended that to not only are you a member of whatever affiliation, but you say you're in recovery, you're in recovery. And folks really struggle with that sometimes. Betty Ford Institute convened a bunch of people together in 2007. Recovery Research Institute are the new kids on the block, recoveryanswers.org. It's still it's complex and beautiful, but it's still a substance specific definition. I'm a fan of, and I embrace SAMHSA's definition of recovery, Because I know in my own personal recovery over the last 17 years that it is a process, not an event, that it is not a destination, it's the journey. And SAMHSA understands that this process of change and what are these goals that we're working toward? Improvements in health and wellness, going towards self-sufficiency, self-directed, freedom to choose. And they're even throwing in a little dash of self-actualization in there, but that is still self-defined. What do you want to be when you get big? You know, what is the purpose of your life? And you ought to have no barriers in the way of you coming to get you some of that. So that's the one I like. I put 12-step in there. This is based upon my experience. While I have been in recovery for nearly 17 years, I have been a member of that culture for over 3 decades. Okay, recovery is a nonlinear pathway, and it is often filled with recurrence and return to use, and going off to learn a little bit of this and a little bit of that. So I have been a member of this culture for over 3 decades. I have been to convenings of these people in many countries throughout the world during my travels. As a sailor, I have read every bit of literature hungrily that has been produced by these organizations, and I am basing this upon my experience. And then conducting a survey with my peers on social media, I threw out my definition out there and got some rough feedback from folks, and it has been refined. It has been refined. But we don't talk about what is recovery in 12-step. You know, we talk about, you know, sober, I guess. We talk about doing the deal. Are you doing the deal? Do you want what she has? Okay. So holistically speaking, what does that person possess? Well, that person is abstaining from alcohol and other non-prescribed drugs. It's abstention from alcohol and non-prescribed drugs. You notice that I put in here that it's unofficial, and it's not to be confused with tradition 3, which means you can come and get you some if you want to abstain. And that's the process there. But I also throw another caveat in there as it relates to Narcotics Anonymous. And this is a fact in that culture, and it is their choice as a mutual aid society to say that if you are prescribed opioid agonists like methadone and buprenorphine, you are not considered clean in that society, which is their word for abstinent. And that's their choice. But we have to be honest about this, that if we're sending folks on buprenorphine or methadone to Narcotics Anonymous, they are welcome and they are a member. But within that society, they will not garner clean time. They will not chair meetings. They will not hold office or positions of responsibility within that. And it's up to each group whether or not they're even allowed to speak. Okay? This is a reality, and that's okay. Attending mutual aid meetings and working with a sponsor. So going to these convenings. How many meetings a week do you go to? And this is not against 12-step. I'm a member of that culture, but I'm being honest with you about what the perception of doing the deal is, of what a person in recovery is. And are you going to meetings? Do you have a sponsor? Are you sponsoring? And that is you're having a mentor or menteeing individuals through the recovery pathway, through the 12 steps. And then moving on to committing to working these 12 steps and practicing their underlying principles in all aspects of your life. And what does that mean? The ultimate ends it's a splendid lifestyle. It is a lifestyle. It is a culture. It leads to friendships and purposeful, principled living and a spiritual awakening, a spiritual experience, and mission-driven outreach to others that looks curiously similar to witnessing. Okay, this is a culture, and the ultimate ends, as described even in alcoholics literature, is achieving a God consciousness, or being catapulted into the 4th dimension of existence. Okay, And I'm okay with that. I love it, and I love my people. But is this a construct that ought to underpin health and justice policy and practice? Is this a construct that ought to underpin addiction professional practice for people experiencing mental disorders and homelessness and trauma, people who are religious averse? I say no. I say within the profession, let's embrace the SAMHSA definition. In our personal lives, let's embrace whatever affiliation that brings us the ecstasy that we have experienced in recovery. And this I tell you as a member of that society.
Hey, Donald, would you mind hitting hide over there next to stop sharing so that we can read the definition underneath the Recovery Research Institute?
Oh, goodness. Hit hide. Okay. And, oh,
Perfect. Thank
gotcha. Oh, yeah, I'm going to keep that hidden. Can you still see my?
you. Yeah, perfect.
I
Thanks so
didn't
much.
know that you could see that. Glad I didn't have anything else up there that I thought you couldn't see. Okay, Recovery Research Institute. Please visit Recovery Resources, recoveryanswers.org. They are a repository for all of the research relevant to this space, particularly an understanding of the role that inaccurate and stigmatizing language play in propping up discriminatory barriers to wellness. And in a call for unified behavioral health lexicon, they created the addictionary. So if you or your staff or your family or whatever have some doubts, of, can we still say addict? Can we still say substance abuse? I'm not sure. Jump on the addictionary, hit that word, and it will give you a flag if there's question about it, or if there's smoke and gun evidence, and it will link to that evidence of any negative valence associated with that word. And to answer those questions, no, we don't say substance abuse anymore. We don't say it anymore, so stop saying substance abuse. That we are clear on. It makes you sound so 2012. And 2013 DSM-5 more accurately describes our experiences with alcohol and other drugs through a spectrum of severity, mild, moderate, and severe substance use disorder. We also have compelling evidence showing that that is one of the terms, substance abuser, that hijacks the brains of even the most well-meaning among us, leading us to less therapeutic responses when we encounter behavioral issues, and trending towards more punitive responses. So stop saying substance abuser. And as an addict, that is a cultural self-identification label. People in Narcotics Anonymous get to call themselves addicts and feel that joy and power that comes from that word. You in the healthcare profession, you journalists, you policymakers and funders, that's not your word. You don't get to say it. It's a label. It's a label. And as we look back on our definition of stigma, it is when we label people, reduce them to an attribute that has a negative valence, and it discredits the rest of the content of their character. Our brain gets hijacked by a word and we discriminate. Let's don't let it happen. Okay, if you're in Narcotics Anonymous, you do you, brothers and sisters. And but if you're in the helping profession or a profession, or you're not a member of that culture, I'm sorry, you don't get to use that word. Said it. Let's talk about some tools. One of the very helpful tools out there that I've discovered is recovery coaching, a harm reduction pathway. Now, I attended Recovery Coach Academy through the Connecticut Community for Addiction Recovery. I'm a recovery coach professional, along with my clinical license in North Carolina. I'm recovery coach informed in my macro social work and in my practice. But Jim Wolfing, one of the original designers of CCAR's Recovery Coach Academy, and a splendid fellow named Dean Lemire, came along and said, we need to blow up education a little bit more as it relates to people who use drugs, people who practice moderation, people taking medications for opioid use disorder, et cetera. Exploring these potential biases that we may hold and not letting them get in the way. And how do we go about doing that? Well, one way is, and I have shared this with permission of Dean. I reached out. He said, "Heck yeah, share it." And I'm sharing it. It starts with exploring your values. How do you know what you value? How do you know what you believe unless you ask yourself that? Or even better yet, ask yourself that within a safe group setting with your peers. And we have to discover what we believe. I believe people's needs in recovery differ significantly, or I don't. They're all the same. And that's your belief, that's your value. And that's okay, but know where you are. I believe that people need to medication to support or initiate recovery, or I don't believe that some people need medication. Know what you believe, know what you value, engage in this values exercise on the down low if you must. I don't want you to fear getting canceled, to explore what's driving you on the inside. And the values exercise goes on. I believe harm reduction is a process of health and wellness. I believe harm reduction is a step in a process to health and wellness. Okay, that's okay. Some people believe that buprenorphine is a recovery initiation medication. Some people believe buprenorphine is a medication like any other chronic illness recovery management medication. The taking of it may be of an indefinite period that is generally agreed upon between the participant and the professional. Okay, know what your values are. We move on to exploring additional values. Even more values here, so that there's not a paucity of questions that you can ask yourself, but these often go unexplored. What do I believe? What do I hold true? What do I value? What am I passionate about? Explore these things. You owe it to yourself as an addiction professional, as a peer, as a clinician, as a healthcare professional. Implicit bias can hijack you as well. Now, from JCO, Joint Commission, and many hospitals and treatment centers may be Joint Commission accredited or CARF accredited. And Joint Commission came out with a helpful issue 23, April 2016, in their quick safety guide on how to address implicit bias within healthcare. And I simply stole this and adapted it to this particular issue. So if you discover, after exploring your values that you hold as it relates to people who use drugs, people experiencing addiction, or people in recovery, and you have discovered that they may be building a potentially negative implicit bias within you that could contribute to unintentionally substandard care, after you explore that, well, then you're going to want to do something about it. And I found that these are particularly helpful cognitive exercises because that's what we need. We need solutions. Perspective taking is the cognitive component of empathy. Empathy, some of us are more empathic than others, but empathy can be a practice. And it starts with the willful decision of trying to place yourself in that individual's shoes, trying to see it from their point of view. How would you respond if you were in the same position? What factors might contribute to how that person is acting in a particular setting? Increase your exposure to diverse groups of individuals, people who use drugs, people in recovery, people experiencing addiction. Spend more time with them. Learn about their culture by attending community events or exhibits. This will increase your empathy, but it begins with perspective taking. And I finally learned to do this. And my wife is a healthcare professional, a veteran labor and delivery nurse. She engages in perspective taking. We can look at someone from our lens and it makes us feel some kind of way. We're baffled and vexed by their behavior, but we pause for a moment and we take a look at them, that person, in their context with their circumstances. We look at their history of childhood trauma or trauma. We look at their I
think we lost Donald again. Just give him a second to come back. There he is.
Sorry about that, brother.
No, don't be. It's all right.
And share
Technology
screen.
when it works.
Thank you for your patience, everyone. And let me hide that. Bam. Live and learn. That's a helpful tool of increasing empathy, is perspective taking. What's this individual going through? I'm not sure when I dropped off, but that is the end of it. As we move forward, emotional regulation. If we are experiencing implicit bias, unconscious bias that sneaks its way out into our behaviors, that is emotional dysregulation. Who wants to be hijacked by a perspective, by a stereotype, by an inclination? And our patients, our participants, our clients see it in our face, see it in our behavior, hear it in our words, hear it in the tone of our voice. Compassion is a thing. Compassion is an incredible tool. Judgment, derision, impatience, and anger are toxic to individuals who are unwell and marginalized. So take the time. Take the time to pause and reflect in order to reduce reflexive reactions. Take time to reflect on potential biases and replace them with positive examples of a stereotype group. I understand that we're not rats in a cage, but these cognitive exercises work. Replace that stereotypical image with a positive image. Practice mindfulness in your practice. Try to meditate. Practice yoga. Focus on breathing. Breathing is the number one thing. You feel in some kind of way, it's about to pop off. You paused for a moment, you've brought more oxygen to the brain, and you're less likely to make a mistake with a person in a potentially lethal mistake. Become aware of your thoughts and actions. Partnership building. If you recognize that your response to a person might be rooted in biases or stereotypes, make an effort to consciously adjust your response. Consciously adjust your response. Your inclinations to say, what the hell are you doing? Your consciously adjusted response is, I want to learn more about what motivates you. I want to learn more about what you value. And I know we don't always have time to do this, to engage in motivational interviewing exercises with folks, but maybe your staff is robust enough to have someone else do it. Or get savvy to SBIRT and learn how to integrate it as seamlessly into your daily practice. Screening, brief intervention, referral to care, SBIRT. Focus on seeing people as individuals. We have an inclination to group individuals into marginalized groups, especially when they're different than us. Rather than focusing on stereotypes that define groups, what about Tom? Okay, Tom is a member of this marginalized group for which I have a stereotype. Let me get to know Tom, the individual, the son, the father, the mother, the daughter, considering them on a more personal and individual level. We have the time, the moment in time to do this, especially if it's going to increase positive outcomes. And I guarantee you it's going to be a level of self-care as well. It's going to decrease burnout. It's going to decrease compassion fatigue. You're going to feel good about it. I'll guarantee it. Professional ethics and values. When in doubt, and I love how Joint Commission words this, assiduously practice evidence-based medicine. Revisit, learn, embrace your certifying bodies and associations, values and ethics. Revisit your clinical practice guidelines, your evidence-based interventions. Doff your affiliation hat, your cultural hat, your societal hat, whatever that may be, and don your professional provider hat. These are some great exercises that I presented to you. Then you can, once you've explored your values, know where you are, you've acquired some practical tools, you've also revisited your ethical considerations, and you've revisited your organization's policies and procedures, because these play a role in it as well. And you bring all these tools in, and then you practice. Okay? because it is not a matter of if these situations arise, it is when these situations arise. Okay, here in this role play scenario, we have a peer professional in sustained recovery who experienced a trauma. 5 years in recovery, experienced a trauma, exemplary performance record, has returned home to a friend who has lost his or her life and experiences a brief return to use, self-medication to medicate emotional pain, and has the wherewithal, the recovery capital in place to say, what have I done? This ends this now, and time to get honest about this. And how do we respond to that person? Like, David, nicely done. I'm sorry that you experienced this. Let's get you the help and support that you need. Let's talk about it. Or do we kick them to the curb because of some policy and procedure where if a peer professional has a return to use, that's the end of that? Context. Emma's a peer support specialist, and you're hiring a peer support specialist who is taking medications for opioid use disorder. This is going to come up. What's your attitude towards opioid agonist medications? Explore these attitudes, these biases, explore the harms that could potentially happen. Here we have a new client experiencing PTSD, sexual trauma in a faith setting, trouble trusting men. She's an atheist, okay? This is a really exquisitely defined history, but brief, and you can learn this quickly. What's your go-to for referral for mutual aid? Well, obviously Alcoholics Anonymous, because she has alcohol problem, or rather in this instance, Narcotics Anonymous. Explore this. This is an ethical consideration that one must consider. And I've published something through National Association of Social Workers regarding informed consent when referring people to peer recovery mutual aid societies. And this individual, Jill, is a case study for why I had that published. And I'm happy to share that with folks. 12-step peer recovery mutual aid is amazing. And evidence supports its efficacy in sustaining recovery, enhanced recovery from severe substance use disorders. However, there are also some potential harms that may come, and sometimes individuals may not be perfectly a fit for maybe the mutual aid society that's in your neck of the woods even. So you have to explore what's out there for folks. Which meetings are women's meetings, which meetings are more secular or less secular, etc. And which meetings maybe are not in a church setting, because we often, through the grace of our faith communities, are allowed to convene in church basements with very low rent. And part of our declaration of self-sufficiency is that we pay our rent. But we're grateful to churches for making that a little bit easier. But some people, as part of their recovery, may not need to go back into a church, or that is exactly where they need to go, right? But not everybody is the same. And you get to explore those values when you explore, dig into your values. Here's one that comes straight from recovery coaching, a harm reduction pathway. And this is pretty hardcore stuff right here. This is the person you're working with believes you support harm reduction, comes to the next session, pulls out a bag of what they thought maybe was heroin they bought on the street. And they want you to help them test it to see if fentanyl's in it. This has become a bit dated. It's pretty hard to find heroin on the street. There's only fentanyl now. But these scenarios happen. We have to explore our values. We have to see if they exist as biases, conscious or implicit. We have to see if they are beginning to manifest as structural or behavioral or practice barriers to people finding the wellness and freedom that they deserve. We need to convene together in safe peer groups to learn tools to mitigate the harm that comes from our biases, which are neither positive nor negative. They're simply potential culturalized misunderstandings of individuals, or just a passion we have for a way of life that has given us the fourth dimension of existence. But as an addiction professional, you have a responsibility to hold that space. And this is my contact information. Donald.mcdonald@allsober.com. My digits. Follow me on social media. I'm not trying to be thirsty or whatever, but follow me on social media. Follow All Sober on social media. I love to holler into microphones, and I love to share about recovery activism, the ecumenical recovery movement, and recovery community centers and PI in your neck of the woods. And I almost hit leave studio.
Donald, thank you very, very much
for your
time and talk. Your lived experience, I think, lends perspective that most people aren't aware of. And I really, really appreciate everything you've done for Project Open, getting us up off the ground and legitimizing some of our operations. We can't wait for you to come down to Dixon to visit the recovery community organization here. And I
love Dixon, Illinois.
Pie for days. All right.
Okay. Pie for days. Let's do it.
Thank you so much. Thanks, everyone, for tuning in. And we'll talk to you next week. Thanks. Bye.